Okay.
Alrighty. Good morning, everyone. Happy Wednesday. Thank you so much for joining us. My name is Tiffany Holmes, and I am the Beauty Justice Outreach Worker here at Black Women for Wellness, working on the Beauty Justice team. I will give a quick introduction to our Director of Programs, Arnitra Jordan.
Hi, everyone. Thank you for joining us. So, for those of you who do not know me, my name is Arnitra Jordan, and I'm Director of Programs at Black Women for Wellness. And for those of you who do know me, great seeing you this morning. I am on my phone because you guys know how bad my Wi-Fi is in my house, and I had to take this meeting from my house. So, it's great to see all of you, and thank you for joining us.
Great. Thank you so much, Arnitra. Today we are commencing our Keep in Touch session. So this is really a breast health, an opportunity for Black women to get together and their allies to talk about breast health, recruiting keynote speakers who are here to speak to us to build community about how we as a community can better serve ourselves and our community members on our breast health. This month's theme is Reclaiming Health, Restoring Hope, Breast Cancer Resilience Through Knowledge and Community. We want to thank you so much, Dr. Versha Pleasant, for coming, taking the time out of your busy schedule to speak with us today. We're super excited. I'm going to introduce our speaker, but for this month's Keep in Touch meeting, it really does center in empowering women to protect their breast health through knowledge, prevention, and community. Dr. Versha Pleasant will discuss the importance of understanding family cancer history, navigating genetic and inherited risk, and recognizing factors such as dense breast tissue. So, a little about our speaker today. Dr. Versha Pleasant was born and raised in Philadelphia, Pennsylvania. She completed her undergraduate studies at the University of Michigan, receiving a Bachelor in Arts in French. She then completed a Master of Public Health at Yale University, and she earned her medical degree from Georgetown University School of Medicine. Dr. Versha Pleasant completed residency training in uh, obstetrics and gynecology at the University of Michigan and then completed a fellowship in cancer genetics and breast health at the University of Michigan. Yes, degrees, yes. She currently serves as a director of the Cancer Genetics and Breast Health at the University of Michigan. She serves on the FIGO Committee on Breast Health and is the co-founder of the National Cancer Genetics and Breast Health Working Group. She provides medical and surgical care for patients at increased risk of breast and ovarian cancer. And she also provides specialized care to breast cancer survivors. Her research interests are focused on universal breast cancer risks assessment and breast cancer related health disparities. Thank you so much for coming today, Dr. Versha Pleasant. We really appreciate it. And feel free to begin whenever you get the chance.
Wonderful. Thank you so much, Tiffany, for that introduction. Arnidra, thank you so much for having me today. Your entire organization. It's really an honor and a pleasure to be here today. I'm going to go ahead and
Thank
share my
you.
screen. And if someone could just give me a quick yes that you can see the screen.
Yes, I can see your screen.
Wonderful, wonderful. Again, my name is Versha Pleasant. I am director of the Cancer Genetics and Breast Health program at University of Michigan, which is one of the few programs in the country that really focuses on people at high risk for breast cancer due to family history, due to gene mutations. And we also provide specialized gynecologic care to breast cancer survivors. Today, we're really going to focus on breast health and cancer genetics. How can you be the best version of yourself, the healthiest version of yourself when it comes to breast health and being aware of your breast cancer risk? So let's get started. I have two disclosures. The first one is that I'm owner and consultant for Pleasant Consulting LLC, which is a company that basically gives lectures on cancer genetics and breast health. There are also pictures of breast tissue in this presentation, just a heads up. So I really enjoy giving presentations like this, especially to Black women, because there are so many stories of Black women undergoing various health journeys in which maybe they are not heard, for which their stories may be undervalued. in which they're really struggling to find their voice in their healthcare journey. And so I really want you to think about that today. And I want to empower you with information today. I want to empower you to be the healthiest version of yourself when it comes to breast health and your breast cancer risk. Let's take a step back first and think about how breast cancer impacts our country. It is the most commonly diagnosed cancer in the United States among women, 13% prevalence, in which 1 in 8 women will be diagnosed with breast cancer in their lifetime. 1 in 8. Think about 8 women that you know in your life, right? Loved ones, siblings, parents. 1 in 8 will be impacted. Every 2 minutes, there is a new breast cancer diagnosis in this country. So you can imagine how many more breast cancer diagnoses there will be by the time that I'm done this talk. This is a pictorial representation from the American Cancer Society, and I'm just showing you here that breast cancer is way up at the top of the list in terms of most commonly diagnosed cancers, and then is the second leading cause of cancer death after lung cancer among women. Now, that being said, despite how prevalent breast cancer is, it actually carries a very, very good prognosis, meaning that most breast cancers are caught at stage 1 and 91% 5-year prognosis, meaning that most women, 91% of them, are still alive and doing well after 5 years from their diagnosis. However, things are a little bit different for Black women. This graph is essentially showing mortality. This is death related to breast cancer. And if you see that light pink line that is floating above all of the other lines, that is death related to breast cancer by Black women. Okay, so Black women have the highest mortality compared to all other racial and ethnic groups as it relates to breast cancer. And we now know that this prevalence, that this risk of mortality is about 38%. So they have a 38% higher risk of dying from breast cancer compared to other women. There are also higher rates of what we call triple negative breast cancer. This is a more aggressive subtype of breast cancer that is harder to treat. There are also higher rates of early onset breast cancer, meaning breast cancer that's diagnosed in younger people, 50 years old or younger. So, really, prevention and early detection are key for all women, and particularly for Black women. Self breast awareness is important, being aware of what's normal for your breast tissue, which we'll talk about in a second. Screening mammography is critical. Know your family cancer history. Consider genetic testing if indicated. And we're also going to have a few moments to talk about healthy living and how lifestyle can play a role in decreasing breast cancer risk. So, the first thing I want to stress is self breast awareness. Know what is normal for your breast tissue. So, I often have patients say, well, I don't really want to touch my breast because my breasts feel like a pack of rubber bands, right? Everything is lumpy, bumpy, and people get very nervous by that. Well, everything feels like a lump. Well, that may be the case, especially for people of reproductive age, right? It's very normal for the breast tissue to feel lumpy and bumpy. But the more you touch the breast tissue, the more familiar you will get with the breast tissue. And then you may notice one day if within that pack of rubber bands, you notice something new that feels like a jelly bean or a marble or pebble or a pea, right? And this is when you want to then go to your OBGYN or your primary care physician and say, hey, I feel something that's different, regardless of your age. And breast self exams are really just things that are done periodically. We used to previously recommend that women do a monthly exam in the shower. Now it's just kind of like intermittently to feel the breast tissue and be aware of what's normal for you. So, some warning signs, right? Anything like crusting nipple or sort of flaky, crusty nipple or discharge from the nipple, right? And here's a picture of that here. Um, this clearly is abnormal, right? When you notice, deepening red tissue or a mass that's coming out from under the skin or a mass that you're able to palpate, any sort of skin changes that are new or different. And then here's a picture of a nipple that looks like it's starting to invert, right? And inverted nipples can be a normal thing. Some people normally have inverted nipples and they've had it for a very long time. But new inversion is definitely something that we start to worry about, right? So if you're noticing that nipples are now all of a sudden starting to retract or invert, or if you notice what we call peau d'orange, which is in that bottom picture, where you have this like kind of dimpling of the skin, which could potentially suggest that there's some blocked lymph nodes. Okay, so these are all warning signs. Skin changes, nipple discharge, palpable mass on the breast, or nipple inversion, or any sort of other skin changes like this that may be new or alarming to you. So how do we screen for breast cancer? Mammogram is really the standard of care for screening. And we know that mammograms save lives from breast cancer. We've known this for a very, very long time, especially if we began mammograms at 40 years old. And there's a lot of data out there where different organizations are recommending different things. And it creates a lot of confusion in the medical community. And patients may say, well, gosh, when do I start a mammogram? At 40, at 50? Do I do it every year? Do I do it every other year? I like to go by the National Comprehensive Cancer Network, or NCCN. And this is the big governing body in the United States that decides all of the different cancer screenings and cancer treatments for people nationwide. And they recommend a mammogram every single year, starting at age 40. And I think also, given the increased mortality that Black women have related to breast cancer, we cannot afford to be skipping years doing with mammograms or starting at later ages. It's really important that we start at age 40 and that it happens every single year. Now, a mammogram is an x-ray of the breast tissue. And people often ask, well, what about 3D mammogram? Should I be getting 3D mammogram? 3D mammogram is also called tomo or tomosynthesis. So those are all the same thing. And at this point in time, even though 3D mammogram is not technically the standard of care, clinically, a lot of providers order 3D mammograms at this point. And essentially what it is it is a 2D mammogram that the way in which we would previously do mammograms. But then the machine afterwards forms an arc over the breast tissue, taking a series of images. And that creates a 3D representation of the breast tissue for the radiologist. And it's great because it gives the radiologist just more data on the breast tissue. It's not a still image. It is FDA approved. It results in fewer callbacks. And so, really, if you're confused about whether you're getting 3D mammography, you're welcome to ask your physician, hey, are we ordering 3D mammogram? Because it really does give the radiologist more information on the breast tissue. These are the different categories that a radiologist will give the mammogram once the report comes out. BI-RADS, or category 0, essentially means that the radiologist needs a little bit more data and they may call you back for additional imaging. BI-RADS, or category 1, is negative. BI-RADS 2 is benign. BI-RADS 3 is probably benign. And I just want to mention this briefly because this is can be a point of incredible stress for patients when they see probably benign, right? What exactly does that mean? That means that there is a 98% chance or more that this is benign. But radiologists want to be conservative. And if they see anything, if there's any small chance potentially of malignancy, 2% or less here, they want to just bring you back for some short-term follow-up. Okay. Anything higher than this, like a BI-RADS 4, usually buys a person a biopsy. BI-RADS 5 is highly suggestive of malignancy, and BI-RADS 6 means we know that this person has cancer. This comes up a lot in my clinic. What about dense breast tissue? So I first want to start by saying, well, why are we all of a sudden having a conversation about dense breast tissue? The reason why is because there is a law in place now that requires healthcare providers to inform patients if they have dense breasts. Okay. And so that's why you may see in your mammogram report or the letter you get after your mammogram, hey, you have dense breast tissue. And it can be alarming because it also may say this increases the risk of breast cancer or it decreases the sensitivity of mammogram. So let's break that down and talk about that a little bit. So first of all, how many people have dense breasts? Well, about 50% of the population has dense breasts. That's about half. Dense breast tissue is diagnosed by a radiologist when you get a screening mammogram, ideally. And these are the 4 different categories of breast density: fatty, scattered, fibroglandular, heterogeneously dense, and extremely dense. And as you can see, these are all kind of subjective designations that the radiologist is giving a patient. And as you can see, as we go from left to right, things become a little bit clearer in the breast tissue to then more dense and more white, right? And with that increasing density comes increased risk of breast cancer. And so there are some reasons for that, biological reasons that we don't quite fully understand yet. But one of the reasons why dense breast tissue elevates the risk of breast cancer is because it decreases the sensitivity of mammogram. So if someone has dense breast tissue, it shows up as bright white on the mammogram. And another thing that might show up as bright white is a cancer or calcifications or a mass, right? So you can see in this picture here, if you have a bright white object on a bright white background, it just makes things really hard to see, okay? Dense breast tissue is more commonly seen in Black patients. We already talked about the fact that providers are now required to inform patients of this, but my only issue here is that there's no universal consensus on any supplemental screening that we should be offering patients. We're going to talk a little bit about what two particular organizations are recommending. But the issue here is that there's no universal practice yet on what we're doing on top of mammogram for people with dense breasts. So it's really important here to check with your insurance company to see what is covered, because this really differs widely based on insurance companies. The only FDA approved modality for dense breast tissue is 3D ultrasound, which you can see here. But a lot of the data really has been looking at breast MRI as a modality that really sees breast cancers at really small sizes and is very, very sensitive for detecting breast cancer. This is the American College of Radiology that is essentially saying for women with dense breasts who desire supplemental screening, a breast MRI is recommended. And if you can't get a breast MRI, you can consider other modalities like ultrasound or contrast enhanced mammography. This is National Comprehensive Cancer Network, who also say you can consider breast MRI with and without contrast. And if you can't undergo MRI or it's not available, can consider other modalities like contrast enhanced mammography or another form of imaging called molecular breast imaging. Okay, really important. I encourage people to contact your insurance company ahead of time, because I've seen situations where patients get a breast MRI that was ordered by their physician simply for dense breasts, and insurance would not cover it. And breast MRIs cost thousands of dollars. They're very, very expensive. And unfortunately, a lot of doctors don't understand and know what things are covered and what things are not covered based on insurance plans. So it's really important to check with them, because it's not quite the standard of care yet, but it's an option available to you. What I'm going to switch gears and talk about now, though, is that there's a lot of focus on dense breast tissue nowadays. And I totally understand that, because it is a risk factor for breast cancer. But there are also other risk factors for breast cancer, namely things like family history, having a strong family cancer history, or having a known gene mutation that elevates the risk of breast cancer. And those people not only have additional options available to them, like earlier screening, breast MRI, but they may have a host, a myriad of other medical options available to them. So I use that as an opportunity, as a door to say, gosh, let's sit down and actually talk about other risk factors that you may have for breast cancer. Now, most breast cancers are sporadic, or what we call random, right? They unfortunately happen because of a perfect storm of bad luck and things like diet, environmental exposures, other risk factors coming together to form a cancer. But we also know that about 15 to 25% of breast cancers might be hereditary, right? They might be related to a family history of breast cancer, and 10% of breast cancers might actually be associated with a gene mutation. And when we talk about gene mutations, to better understand this, right, we get half of our genes from mom and half from dad. And if mom or dad or both have a harmful gene mutation, there's like a 50-50 chance that they may pass it on to any living children, regardless of whether they're male or female, right? And this is specifically for the breast cancer genes that we're talking about. So, why do I have a picture of Angelina Jolie? I love Angelina Jolie, for not only for a lot of the advocacy work that she's done in movies and things like that, but she is a huge proponent of genetic testing and people knowing their risk. And why is that? Because Angelina Jolie's mother had breast and ovarian cancer. Angelina Jolie got genetic testing and found out that she has the BRCA gene mutation, or BRCA. And she inherited that gene mutation from her mother. It's a harmful gene mutation that elevates the risk of breast cancer, ovarian cancer, and other cancers. And upon discovering this, Angelina Jolie had all of the necessary steps and medical interventions to decrease her risk, and she's alive and well today. These are all things that, even though Angelina Jolie is rich and famous, these are all things that are also available to you today. And again, I want to empower you with this information and encourage you to seek out the care that you need. And we're going to talk about where that starts today. How do we find out who should undergo genetic testing for gene mutations? The first step is what we call a risk assessment. So that means that you sit down with a healthcare provider and you review the family cancer history. There's a lot of risk factors for cancer, but family cancer history is like a window into risk. It provides a lot of it is highly predictive of risk. And then as we review that family cancer history, we would determine if genetic testing criteria are met based on that. Going back to the American College of Radiology, they recommend that all women, particularly Black women and Ashkenazi Jewish women, have a risk assessment by age 25. By age 25. So that means we need to be sitting down with patients and talking about their family cancer history by age 25, which I would argue is not really being universally done at this time. The National Comprehensive Cancer Network also says that by age 25, people should undergo a risk assessment. This is really, really important. I get very excited in my clinic when I have people in their 20s that come and see me for an evaluation of their cancer risk. That's the perfect time, right? We should not be necessarily waiting until it's time for screening mammogram at age 40 or beyond, right? And of course, it's always better that we review family cancer history first so that we can detect cancer early and potentially prevent it. So, how do you take a family cancer history? I also want to say that I absolutely love giving these talks around the holidays because this is the perfect time to sit down with family members and to talk about family cancer history because everybody is going to be there. We have Thanksgiving coming up and the holidays, Christmas. So, sit down and document who had what cancer, what is their relationship to you, the age at the cancer diagnosis, and if this person is still living, and if not, the age of death. Okay. And this is important because, all right, we talked about how breast cancer is the most commonly diagnosed cancer in the United States. So, do I want to know if paternal grandmother had breast cancer at 80 and died at 90 of a heart attack? Yes, I still want to know that and I will still document that. But I'm a lot more concerned when I hear that paternal grandmother had breast cancer at 40 and died at 42 of metastatic breast cancer, right? Because that's giving me an indication of how aggressive this cancer is. And like we said, when we have these early diagnoses of breast cancer and any cancer, in fact, that makes us more worried that there's a genetic component to that. It's important to ask about the type of cancer. You may remember that I mentioned earlier in this talk that Black women are more likely to get triple negative breast cancer, which is a more aggressive subtype and can be associated with gene mutations. So, if someone has a breast cancer diagnosis, you may just want to ask that question, hey, do we know if this person had triple negative? And write it down if we do know that. People meet criteria for genetic testing regardless of age if they've been diagnosed with triple negative breast cancer. Both sides of the family matter, and males and females both matter. And so, why am I saying this? I've had so many patients, when we sit down to take a family cancer history, they will only tell me about their maternal side and they will only tell me about breast cancer. And I say, well, what about dad's side? And I say, oh, well, I can't get cancer from dad's side. That is not correct. You can get cancer, you can inherit a cancer susceptibility gene from mom's side or dad's side, okay? These genes don't care if you're male or female, okay? They can be passed on to the next generation regardless. And I want to also know about all types of cancers, right? Not just breast cancer, because BRCA or BRCA is called the breast cancer gene, but the reality is there's other cancers that travel with that gene, ovarian, prostate, pancreatic, melanoma. So again, I care if maybe dad had prostate cancer at 60 and died at 65 of metastatic prostate cancer. That is a huge red flag. And not necessarily just because it's prostate cancer. If you remember from that American Cancer Society table that I showed you, prostate cancer is actually way up there. It is the most commonly diagnosed cancer among men in the United States. So it's very common, but it tends not to be a particularly aggressive cancer. Most men die with prostate cancer and not of prostate cancer. But again, if we see family members dying of metastatic prostate cancer, that raises red flags. Here are the most recent NCCN genetic testing criteria. It's a lot of text here, it's a lot of data, and this can be really hard to interpret at times, both for patients and for providers. So here are a list of kind of red flags, some sort of highlights from that table. You should be concerned if there are multiple breast cancers in the family, particularly on one side of the family. Breast cancer at 50 years old or younger. This is considered early onset breast cancer. Triple negative breast cancer at any age raises a red flag. Metastatic prostate cancer, male breast cancer. Yes, men can get breast cancer as well. This is a huge red flag and raises concern for things like BRCA or BRCA. Ovarian cancer, a very aggressive cancer that is not as common as breast cancer, but also can travel with some breast cancer genes. Pancreatic cancer, same there, not as common, but a very aggressive cancer that's hard to treat. And having a known gene mutation in the family. So if you know that there's a family member, a cousin or aunt or uncle, grandparent that has BRCA, that could be a strong indication for you to get genetic testing as well if parents have not been tested yet. So how does testing work? So you first meet with a genetic counselor, either virtually or in person. You must provide written consent prior to testing. So no one's going to perform genetic testing on you without your consent. That's very, very important. There is the option of doing saliva or blood draw, although at this point in time, most genetic testing really consists of spitting in a tube. And then it takes about 2 to 3 weeks to process. And then after that, you meet again with the genetic counselors. And this is really important. Even if your genetic testing results are negative, it's really important to still meet with the genetic counselor and discuss those results, because there could be a next step after that, which we'll talk about. So if a harmful mutation is identified, you might be eligible for a number of different things, including additional screening with breast MRI, medications that can actually decrease breast cancer risk, tamoxifen being one of them, which you may or may not have heard of before. The option of risk-reducing mastectomy, and I want to highlight here the word option, because a lot of patients say, well, I don't want to get the genetic testing because I don't want to have my breast tissue removed. No one's saying that you need your breast tissue removed. But if you have a harmful high-risk gene mutation, this may be offered to you as an option. And then other cancer prevention options. Again, a harmful gene mutation may not confer only risk for breast cancer, but for other genes as well. If you test positive for a harmful gene mutation, that may mean then that other people need to get tested, such as children or siblings or parents. And then there's the option of what we call pre-implantation genetic testing. If you recall, I said that these genes have a 50-50 inheritance pattern, meaning that there's a flip of a coin that this gene mutation gets passed on to the next generation. Well, pre-implantation genetic testing allows us to test embryos for the gene mutation and then select for embryos that do not have the gene mutation. And that ensures that that harmful mutation does not get passed on to the next generation. We talked a lot about BRCA or BRCA today, and you can see that on the second line here. But I just want to show you this table to impress upon you that there are a number of other genes that we know of now in 2025 that elevate the risk of breast cancer, right? These are maybe not as commonly seen or not as popular as BRCA, but they definitely exist. You can see the cancer risks associated with them. And notice also when the age to start screening with mammogram and MRI begin. And so they're most of them, not all of them, but most of them are before 40 years old, right? And so again, this is why it's really important in early in life to really sit down and talk about family cancer history, because some of these screenings may start way earlier than what we're starting for average risk people. What if the genetic testing were negative? Okay, well, it's still important and it still gives information about family risk. And this is important because people that test negative, if you have a strong family history of breast cancer, you may actually still meet criteria to get breast MRIs once a year or earlier screening. The genetic counselor may then, upon the negative genetic testing results, do what we call a risk calculation. There are software tools where we can enter your personal and family cancer history information and come up with a number. And if that number is 20% or greater, then you are considered to be at elevated lifetime risk for breast cancer, and you may be offered some of the same things, in fact, that BRCA patients are offered for their breast screening. These are other people that are considered to be at increased lifetime risk of breast cancer. So people who have a germline pathogenic variant, aka harmful gene mutation like BRCA, that's the table that I just showed you earlier. People who have a high risk breast lesion. So these are people that have had a breast biopsy in the past, and the pathology is showing what we call atypical ductal hyperplasia, atypical lobular hyperplasia, or lobular carcinoma in situ. These are not precancers, but these are lesions that convey an elevated future lifetime risk of breast cancer. And these patients also meet criteria to get breast MRIs once a year. Lifetime risk 20% or greater due to family history, which we just discussed. And people who are also at high risk for breast cancer are those that had chest wall radiation as children. And these typically tend to be the Hodgkin lymphoma patients, right? So patients who have had radiation to the chest wall between ages 10 and 30. And just one more plug with breast MRI. It's a really, really highly sensitive tool. It does involve placement of an IV because there has to be contrast, gadolinium contrast, in order for the radiologist to appropriately see the breast tissue. And again, supplemental screening for those who are considered to be at high risk. And a little bit different from a mammogram. You see, for the breast MRI, patients are lying flat down on the table in a position called like the Superman position with their arms above their head. The breasts lie in a tray and then they're backed into the machine. I just wanted to address a couple of last questions and concerns that a lot of patients have. Some people will say, I'm afraid to know the results. I don't want to get genetic testing because I'm afraid if it's positive. I hear that. And we cannot unknow information once we know it. But here are a couple of plugs that I want to make. If you take a cell phone and you put the cell phone in a box, and then you put that box in a box, and you put that box in a box, and you lock that box, and then you put that box in another box, the cell phone is still going to ring if it wants to ring. So if someone is considered to be at high risk for cancer, then they may develop a cancer whether they want to know their results or not. And so I would say also that I am very grateful that we are living in a time period where we have the tools to identify people at high risk before they ever get a cancer. And we actually have interventions. We have options, medical options and surgical options for patients like that. And we're not talking about different pathologies here like Alzheimer's or things where we don't have a cure for it or we don't really have an effective treatment. These are things where we actually have proven interventions that can either detect cancer early or decrease the risk of cancer ever coming in the first place. So, but we have to know in order to take advantage of these. We have to know. And I also tell people, depending on your age, you even if you don't do the testing for yourself, you can do it for your children. You can do it for your loved ones, right? We can give the gift of knowledge to each other. And this is really, really important because in some communities there may be a culture of silence and a culture of fear. And I think we can and should change the narrative and say knowledge is power. We can empower ourselves with information and we can actually act on that information. What about cost? This comes up a lot. If you meet criteria for genetic testing, costs are actually typically covered by insurance. We're talking about genetic testing costs. And if positive, some companies will even offer free genetic testing to close relatives soon after you test positive. And so this is really important to keep in mind. Can I get testing even if I don't meet criteria? And the answer is yes, you can. Even if you don't strictly meet those NCCN criteria, everyone still has the right to undergo genetic testing if you just wanted to know for your own knowledge. You can request it from a genetic counselor. The only caveat here is that it may not be covered by insurance. And then the next question is, well, what are the costs? And the out-of-pocket costs are estimated to be about $250. I don't want to assume that's a lot or a little bit for anyone, but genetic testing costs have come down substantially over the years. They used to be thousands of dollars. I'm worried about discrimination. There is a law in place called the Genetic Information Non-Discrimination Act, or GINA. And this law ensures that employers and health insurance companies cannot discriminate against you based on your genetic testing results. So this is a really important law that was passed in 2008. And health insurance companies and employers have to adhere by this law. Now, life insurance companies, disability insurance companies do not have to adhere to this law. So people often will prefer to get their life insurance or disability insurance plans in order before they undergo genetic testing. What are some other ways to stay healthy? Really, really important to have a healthy diet full of fruits and vegetables and grains. There's a lot of data to show that there are reduced breast cancer related deaths with these sorts of diets. And there's a lot of emerging data showing a link between breast cancer risk and increasing alcohol intake. So this is really important. And this is both for estrogen receptor positive and for triple negative breast cancers. Doesn't mean you have to cut out alcohol entirely, but really limiting alcohol. Different societies recommend different things. I often like to tell patients no more than 2 to 3 servings per week. And physical activity is also really important. There's studies showing greater breast cancer risk reduction in African American women who engage in physical activity, and really strenuous physical activity has been demonstrated to lower breast cancer risk, especially for triple negative breast cancer. So these are important things that we can do, things that, we can't change our family history or our genes, but these are things that we can actually do to lower our risk. In conclusion, a couple of take-home points here. Mammogram every single year starting at age 40. Please, mammogram every single year starting at age 40. It saves lives from breast cancer. Be aware of your breast tissue. Practice self-breast awareness at home. Know your family cancer history. This could save your life. This could save someone else's life in your family as well. And if you're confused about your family cancer history and you want a further assessment, or if you met any of those criteria that we talked about earlier, seek out a genetic counselor. See a specialist who can really talk to you about genetic testing, order the testing, and interpret your results for you. Healthy diet and exercise are key. Limiting alcohol is really, really important. And again, I just want to empower you today. Get the information that you need to be the healthiest version of yourself. If a doctor is telling you something or not listening to you, telling you something you disagree with, or not listening to your opinion, it's always okay to seek out a second opinion, right? But I just want to empower you to get the information that you need to be the healthiest version of yourself. I come from 3 generations of breast cancer in my family, and I get really excited giving these talks because I think it's really important for people to open up and talk about family cancer history. And again, use that information to empower oneself and to empower others to be healthier. I want to thank you so, so much for your time and attention today. I'm happy to entertain any questions.
Thank you so much, Dr. Versha. That was amazing. We did have a couple questions in the chat, but first I just wanted to tell you one part of your presentation that really stuck with me is gifting the power of knowledge and being able to take that knowledge into your communities, into your families. And I think that is extremely important and very valid. And the reason why we're here today to, share that knowledge, gift that knowledge to ourselves, and then ideally take it into our communities. So I just want to thank you. It really resonated. We do have two kind of comments/questions from Ms. Deborah in the chat. Ms. Deborah, did you want to just unmute yourself and ask them yourself?
Okay, thank you. Thank you so much, Dr. Versha. This was very, very, very good. I have a couple of questions. The one I'm going to start with first is with the genetic testing. So I was part of a clinical study, and I had my genetics tested. I'm a 24-year breast cancer survivor. I'm the only breast cancer survivor. No, that's not true. I'm the first breast cancer survivor in my family, the first diagnosed with breast cancer. My paternal grandmother had leukemia, which I didn't find out until after I was diagnosed, and I was diagnosed in my 40s. My question is, and I found my own lump, and it was also 9 months after I had had a mammogram. So it was growing pretty aggressively. So my question is, I have a son and a daughter. I also have 2 grandsons and a granddaughter. With the genetic testing, they showed no mutations. And so looking at that, what would be the risks of my children and or my grandchildren developing breast cancer?
First of all, Deborah, thank you so much for sharing your story, and I'm so excited to hear about your breast cancer survivorship. You're doing great, and this is really, really great news. And thanks for sharing your story with us today. I want to just be careful about giving kind of personalized medical kind of advice for your particular situation. It's also going to be challenging just because I don't know the various risk factors that your kids may have and your kids. But what I will say is that you did the right thing undergoing genetic testing. It's a gift of knowledge to your family. And what your children could do, and I'll just speak broadly. So for people that have breast cancer and got genetic testing, children should see a breast specialist or a genetic counselor themselves. One, to determine if there's any risk coming from the paternal lineage, right? because that's where we're getting 50% of our genes as well. And then people in that situation often will undergo a risk assessment. If there's no genetic testing that's indicated, then they're going to get their information entered in these software tools to see if they meet criteria for earlier screening and potentially breast MRIs. So that would be kind of like the next step for people in that situation.
Okay. And then my second question, I do have a nonprofit that works with Black women diagnosed with breast cancer. So one of my ladies went to have her examination, and so she was telling me about the Vera scan, which I actually met a doctor that does do the Vera scan. So she did not use the Vera scan. She went ahead and had a traditional mammography. But do you have any thoughts about this Vera scan? Is it a viable alternative to a mammogram, or is the information just not readily available as to the success of getting a Vera scan?
Yeah, thank you for that question. So, for our audience, Veriscan is like another form of breast imaging using kind of CT technology. And so, we don't really have the adequate data at this point in time to determine if Veriscans are sort of equivalent or superior to mammograms or breast MRIs. The modalities of imaging that have really been well studied are mammography, breast MRI, things like ultrasound, contrast enhanced mammography is starting to demonstrate a lot of really promising data as well. So there's some other breast imaging modalities out there, but really, the research becomes really important here because we know that our collective goal is to detect breast cancers early and decrease the risk of people dying from breast cancer. But we have to show that through research that actually proves to be correct. Through things like randomized controlled trials, right? Comparing something like that sort of scan to a mammogram and to an MRI and comparing those outcomes. And I don't think that data is quite there yet.
Thank you. Thank you so much. I really appreciate it.
Absolutely. Absolutely, Deborah. It was nice meeting you. Thank you.
Right here.
We do have another question in the chat. I can read it. Can I file a complaint against my MD for not giving me a dense breast MRI?
Again, I'm going to speak a little bit broadly here so that I'm not speaking to people's unique situations. But what I will say is that there is no national consensus at this time that for what we should do for people with dense breasts. The two medical societies that I mentioned, American College of Radiology and NCCN, they say that people can consider supplemental screening if they have dense breasts. But the reality is that it's not something that is universally practiced at this point in time. And I would even argue to say that probably most people are not getting supplemental screening yet for dense breast tissue. Now, might that change over time? That's possible. That's possible. And I think with more and more data evolving, and hopefully more advocacy for insurance companies to cover some of this, then those things may change. But the reality is that most people are not getting supplemental screening at this time because there's just no consensus on what that should be.
Thank you.
May
Absolutely.
I make a comment?
Sure.
Um, yeah, regarding the physician telling a patient whether or not they have dense breasts, I think it was, I don't know if it was 2024 or 2023, in California, that the physician, if you're getting an examination, that they are required to tell you whether or not you have dense breasts. I know I have dense breasts, but I think it was either 2023 or 2024, there was something passed in California that they're required to tell you. If you ask, but you have to ask. That's the question. You have to definitely ask, and they're required to tell you.
Yes, there's an act in place, a law in place that requires physicians to inform patients of their breast density. And a patient may notice that a doctor may actually verbally tell you, but you also should look at your mammogram report, because it will, I shouldn't say probably, it will say it in the report. And sometimes radiology suites will send you like a letter saying that you have dense breasts, and it'll go into detail about it, but it should be in your radiology report. So if you have any question about your breast density, that's where you would get that information. If you have not had a mammogram yet or any sort of breast imaging, then you would not know your breast density. So I have some patients actually touch their breast tissue and say, I have dense breasts. That's not how dense breasts are diagnosed. So it really has to be, you have to have gotten some sort of breast imaging, preferably a mammogram, but not always. To determine the breast density. So yes, it is. Thank you, Deborah, for saying that. There is a law in place that requires physicians to tell patients of their breast density, but what does not exist yet is a universal option that we give all patients with dense breasts as to additional screening on top of mammogram. That is the thing that isn't happening yet. And hopefully will change in the coming future. So stay tuned.
Thank you. I actually have a question too. So I'm reflecting on the past week and just hearing a couple of different stories from Black women, unfortunate stories, about how they come into the hospital or to the doctors and they're either, dismissed. This was specifically in context of giving labor, but dismissed, ignored, and turned away from the hospital. And so I'm wondering if you have any tips for women in general, but specifically Black women, in advocating for themselves when they get to the doctor's office, or anything that, they can do to make sure that they're taken seriously when they're in the doctor's. Oh.
That's a great point, Tiffany. And that's why I mentioned at the end, if you have a breast concern or any medical concern for that matter, and you feel like you're being dismissed or brushed off, go get a second opinion, right? This doesn't have to be the narrative that it ends there. And, I have heard many a story that are very similar to what you just mentioned, Tiffany, where something is brushed off or overlooked. And then it turns out to be something serious in the end. There's a chance it may not be, and there's a chance that it may be. And if it's something that is concerning you, go get a second opinion and see what another physician has to say about it. Right? The theme here is really advocating for yourself. You are your best advocate. So, and that's why I showed you those pictures again at the beginning of the presentation, because those were all women that advocated for themselves, right? You have that power in you as well. So speak up, stand up, and don't rest until you have answers that make sense to you.
Thank you so much. I really appreciate it. Are there any other questions for Dr. Versha? Alrighty, I
think we may have one more
yes.
question. While we're getting that question, I really want to encourage everyone again, as the holidays are coming up, right? This is a great opportunity where family members are sitting around, where you have maybe older family members that have a lot of generational knowledge and know for certain what cancers various family members had. Like this is the time to take advantage of this and really sit down and not just talk about it, but document it, write it down, and share it with family members so that they can seek the care that they need. So I just really want to stress the importance of this time of year for a lot of different reasons, but that being one of them.
Thank you. We did get the question in the chat. Should I get a mammogram although I'm under 40 years old, or can I just keep doing self-care breast exams?
Great question, Cherry. So self breast awareness should occur throughout life, right? So that never stops. In terms of earlier screening, so the standard of care in this country is screening mammograms starting at age 40. Okay. But like I said, by age 25, it's important to go over family cancer history, because that could then trigger concern about a gene mutation, which would then prompt genetic testing, right? which could then lead to earlier screening before the age of 40, more intensive screening. So Angelina Jolie, for instance, right? I mentioned that she had BRCA. So BRCA, I see BRCA patients in my clinic. They start breast MRI at 25 years old, 25. And then they start mammogram at 30. So by 30 years old, they're getting a mammogram and an MRI once a year. But we can't start that screening if we don't know that they have BRCA, right? And it takes really like a sitting down and talking through the family cancer history. I strongly, strongly encourage you, if any of you out there have a strong family cancer history, anything that I said in this presentation where you're like, ooh, this may apply to me, go see a genetic counselor. Go see a genetic counselor. Genetic counselors are trained to understand the nuances of genetics and to understand how to interpret family cancer history. And they will let you know if you meet criteria for genetic testing. And if you don't, and you still want that knowledge of your genetics, you can still opt to get the testing. Again, that's another thing I want to just stress to everyone. If you want that knowledge, you can still potentially pay out of pocket to get that information and to get the testing. But that is the venue by which we understand and know if patients should be getting mammograms and MRIs earlier. That's the first step. That has to be the first step.
Thank you.
Mm-hmm.
Yeah, we have another question in the chat too. Margaret asked, regarding second options, are they usually associated with an out-of-pocket cost, or does insurance typically cover them?
That I don't know, unfortunately. And doctors know very, very little about insurance, anything. And I bring up these issues only because these are things that patients brought up to me. I actually don't know if, what it entails about getting a second opinion and if they're out of pocket costs for that. It probably depends on the insurance that you have. I really don't know. But I would argue that if there is a medical problem that is concerning to you, and again, you have not received the information that makes sense to you, you either need to go back to that doctor and understand, you have them explain it in a way that makes sense to you, or you may need to get a second opinion if it is something that could potentially be life threatening or could alter your quality of life. So that is kind of a personal decision to make, but I would also say that your health is the most important thing that you own.
That should be on a t-shirt.
Yeah.
It's a really good point.
Yeah.
Um, Thank you so much. Are there any final questions for Dr. Versha before we wrap up? Alrighty, well, I just want to say thank you so much. I personally have learned a lot from this session. I just turned 25, and so hearing that there's this option for risk assessment, I've never heard that before. And so I want to thank you for, providing us with actionable steps, but also, debunking myths about around breast cancer in our communities in general and how we can show up for ourselves and, advocate for our healthiest selves. We really appreciate it. And with that being said, yeah, we want to thank you. Can we give a round of applause to Dr. Versha?
Yes. Tiffany,
Everyone.
can I say something really quick? Dr. Pleasant, this is the second time I've heard you speak. And every time I learn something new from you. And I am just so amazed at the things that you are doing and the information that I'm able to take back to other women. So thank you so much for coming today and for also just always being so empowering.
Thank you. Thank you. It was an honor and a blessing to be here today to speak with you all. I hope that this information just multiplies.
Thank you so
We will make sure
much.
it does.
Great.
Yes,
Thank you. Thank you. Thank
knowledge
you.
is power.
Mhm.
Um, And before we all hop off, we just want to give a quick reminder that next month, we will not have a Keep in Touch session online. We will actually have our Black Women for Wellness Keep in Touch holiday party. It's going to be December 8th here at our office in Leimert Park. And if you guys are interested, I'm dropping the link to our Eventbrite below so you can RSVP. And we really hope to see you guys there. It's an opportunity just to see everyone's face in person. Um, we're usually online, and so it's a nice switch up. And yeah, just ending the year and celebrating all the hard work we've done. And yeah, I just dropped the link in the chat below. Arnitra, is there any final thoughts that you wanted to
Yes.
say?
Are there any announcements? Does anyone have any announcements, anything that they want to share before we disperse?
Thanks, Arnidra. I actually do. This is Renee from Women Guiding Women at the Todd Cancer Institute. Thank you so much for that informative presentation. I really appreciated being here today. I wanted to share three things. That we do offer genetic counseling at our center. We have a wonderful team, Alex Pacios and Karen Lappin. So if anyone needs any type of genetic counseling, we offer that by master trained facilitators, and they can perform a risk assessment for you. And then the other updates I have from Lillian and I is we have some events coming up in 2026. You're all invited. We'd love to have you. June 13th is our annual Survivor Celebration, and we'll have an educational lecture and serve a complimentary lunch. And then in October, the 17th, we'll have our Spirit Walk in Long Beach. So you're all invited. So thank you so much. Thank you for today. And I just wanted to wish everybody a happy Thanksgiving as well.
Happy Thanksgiving, everyone. Does anyone else have any announcements? Thank you, Renee. Does anyone else have any announcements or anything that they need to share before we disperse? And can I just thank James Johnson from the Watts Health Corporation? I got it right, James. Watts Health Corporation. It only took me 20 years. For our mammograms and manicures during the month of October. It was a really, really nice event. We were able to provide some women with free mammograms thanks to a generous donation from the Fenty Savage Black employees. And also we were able to provide anyone who received a mammogram with a free manicure. So it was a nice touch. And for all of you guys who participated in our bra party, this year we hit 125 women. So we are now too big for our location at the where were we at Skylink? So now we're going to have to move over to the Grand. And our goal for next year is to get 200 women to attend our annual bra party. We're getting better and better as a team. And I want to thank you all for that, because it's because of all of you and the work we do together is the reason why we're able to keep expanding and keep giving the knowledge and providing educational information to all the women in LA County and across the nation. So, Tiffany, if there's no more comments, you can close us out.
We have one more hand raised. Jennifer, feel free to unmute yourself.
Thank you. I know that we all come together united in a cause against breast cancer, but I just wanted to do a quick shout out. January is Cervical Cancer Awareness Month, and we are currently scheduling workshops for the month of January to talk about cervical cancer and cervical cancer prevention in particular, especially since cervical cancer is one of those that is, preventable. If you have a group of people that you would like us to come speak to, we would be happy and honored to schedule time for a workshop with your clientele. So reach out to me. I will send an email for Arnidra or Tiffany to share out with everybody with our contact information so that can be scheduled before the blur of holidays begin.
Yes, and we will make sure to send that out too. Again, happy holidays, everyone. We really appreciate you guys showing up in the space. It's because of you, like our teacher said, that we're able to put on such great events and share the knowledge and share the wealth. And so we want to thank you, and we hope to see you at our holiday party. And if not, we'll see you next year. Happy holidays.
Thank you.
Happy Thanksgiving, everybody. Thank
Thank
you again,
you.
Dr. Versha.
Thank you. Thank you so
Blessed
much.
holiday season.
Everyone.
Thank you.
Good evening for the great work you're doing.